variations have been done in adults, but now people are talking about several procedures in selected children. So, Chapa?
Thank you. All right, so let's go ahead. I'm a regular person. So my life can be divided as before medical school, of course, and after. So before I swam, boxed, got my black belt in Taekwondo, played guitar and piano, spoke 3 languages. But now after medicine, thank you, I don't run. I'm not even to the bathroom. I'm more sedentary than the potato in the back of my fridge. My BMI, it's a little bit on the high side. And I barely speak English, and my Spanish, not that good. I'm still poor after my immigration lawyer took all my money savings, but most importantly, I'm happy and thrilled to be working here at LSU. So the objectives for today would be to talk a little bit about the epidemiology of, I know it's cool, that's what the French do for propaganda. Anyways, so whoever wants, I can have it afterwards. We're going to talk about epidemiology about obesity in adults, in pediatrics, our statistics here in Louisiana, and then talk a little bit about the economic burden of obesity, and then go through the adult experience of the intragastric balloons, and then work our way through our pediatric experience, right? So as here we can see a pictorial representation of our maps throughout time, and we can see that early in 1990, the prevalence of obesity was really low across the states. Around the tops was between 10 to 14%, and as years goes by, this has become increasingly an epidemic. And back in 2010, you can see where we are in Texas and Louisiana. We are above 30% in terms of obesity, and this is for adults, right? The latest CDC review was that it's progressing, and there we go. Louisiana, we are in the 35% of our population is more than 35% is obese, and this is just spreading out. From an infectious standpoint, this is like scary stuff. If you put that this is a bug, everyone will be like really, really jittery about it, right? So with this increased obesity, you can see that there's also progressive raise in diabetes type 2. And again, this is adult statistics, but you can see that again, the darker color would be considered around 12 to 16% of diabetic, or the population of adults are diabetic. And with this, there you go, goes hand in hand with your physical activity. We are all very sedentary, and we're becoming hypertensive. So we're fatter, we're high blood pressure, we are diabetic, and we're like my potato in the fridge, okay? Now, in Louisiana, there you go, 36% of adults in the survey in 2015 are considered obese, okay? And there you go, we're number 1, and this is not the thing that you want to be first, okay? We're number 1 in the country in adult obesity, and as you can see here, from 1990 has steadily and alarmingly increasing to around 36%, like about 3 years ago. On your right side, you'll have a breakdown based on age bracket, and you can see that most of the work class is the one that will have more obesity than the other parts, right? Black people tend to have a little bit more predisposition for obesity, but I don't know. I mean, Latinos, we breathe and we get fat, to be really honest. So I think that there might be some problems in that statistics. Anyways, and that pretty much affects both men and females, right? So this is a very busy table, but I want you to capture your attention to our teenage group. And on the top part, you will see that 33%, almost 34% of our teenagers are considered overweight. And 18 and 13% will be considered obese and morbidly obese. So this is something that is very important because we are graduating these children to adult medicine. And these children will have hypertension, diabetes, and so on and so forth. If you want to scroll back across ages, you'll see how it's not only for teenagers, but it starts very early, 2 to 5 years. You also have already overweight and obesity, okay? And really, again, like adults, it will not make a differentiation between genders. Comparing to adults, this is taken from the NHANES study. We can see a graph across years, and the prevalence of obesity in severe and extreme obesity in pediatrics was actually on the lower side. 10% of pediatric patients were obese back in 1994, compared to awesome 16% now in the last survey, which was in 2014. And compared to extreme obesity, it's like around 6-7%. Some of you will say, oh, the Chapa is just a 2%. Yeah, multiply by 100,000 and tell me if that's something meaningful or not, right? It is. It is meaningful. Why? Because it has a big impact in economics. It's a freaking sinkhole of money. Okay, so the annual direct costs for childhood obesity range about $14 billion, with a B, billion dollars. And then indirect cost, it's another $4.3 billion. So, you know, it just accounts for 27% of your increased healthcare expenditure. So and we're all going to pay for this in a couple of months when we pay our taxes. So this is only the pediatric segment. You're not touching what's the expense in adults, all right? So it really will hit our pockets. So what tools do we have? So we know what we do in clinic, lifestyle changes, and we tell them you need to do diet and reduce your portion, do portion control, try to eliminate carbohydrates, beverages, and things like that. And you need to start moving, okay? You need to do exercise 3 times a day and so on and so forth. But we know that, then we start asking, what's the exercise has an effect on BMI? And yes, it does. So there's this really nice paper that they do, a network meta-analysis. They pull around 2,000 patients from 34 studies, and they assess the different types of exercise that there are available for us. And they found that the sweet spot is you need to exercise 3 times a week for at least an hour for 12 weeks. And if you do that, your BMI Z-score will actually improve. For how much? So if you only do aerobic exercise, you'll have a 29% improvement. That's a lot of improvement. So if you decrease by 10% your weight, you can be off your antihypertensive medications. So it's awesome, right? If you combine it with strength, you might have up to 31% improvement. And your number you need to treat is 2. You cannot get any better than that. Although, we need to understand that there is a catch in these numbers. Might be slightly inflated because when you do meta-analysis, although it's the highest evidence you can get, there might be some bias because there is heterogeneity in terms of the population, studies, and so on and so forth. So they did acknowledge that in this study. But anyways, it's a good thing. But it's a temporary thing. You stop doing this, you get fat again. So we have intragastric balloons, right? And they started in the 1980s, okay? They were cylindrical. They had high rate of complications, and they were really not effective. Around the what happened in other things in the 1980s? Well, we have awesome music, good rock band, okay? And the intragastric balloons came out, right? And because of this thing that I just mentioned, they were banned because they were bad. I mean, complications is they deflate, they got into your gut, and then you have obstruction and your necrosis, and you need to have a very sexy scar from your xiphoid to your pubis, and they need to do the intestinal resection. Not cool. Some of them died, so it's really, really not cool. All right? So what happened with anyone who fails is you will be bitching about it for a little bit until people stop paying attention to you. And then you just stand up, dust yourself, and try a new idea. So that's what they did with this balloon. They reshape it and make a complete sphere. So you don't have any edges that will irritate or cause ulcers or lacerations of your GE junction. And this is a temporary implant designed to facilitate weight loss by occupying a space in your stomach. You can inflate it with 400 to 700 cc's of water. And one of the good checkpoints for safety, they put 10 cc's of methylene blue. Because if they leak, you will notice in poop and urine. Okay? They stay there for 6 months, and this was approved in 2015. So when you look at the evidence, multiple studies have been done, but this was the one that got this thing approved. And this was it's a pivotal trial. It was a double-blind, randomized trial, and a crossover. So what they did is they grabbed Group A, they did an endoscopy, they put a balloon. In Group B, they did an endoscopy, but they didn't put a balloon. 3 months later, they repeated endoscopy and they switched. Now, the one that didn't have balloon, now they have one, and the one that had balloon Now they just don't. And they will follow them with diet and exercise and see how they do. 6 months later, they remove, and that's it. So as you can see, the patient that had the intragastric balloon had a dramatic decrease in BMI all the way to the time when they had the crossover. But importantly, they continued to lose weight. Because remember, they also were doing diet and exercise. And the other people, once the gastric balloon was introduced, they start losing weight. Okay? And I mean, this is a good study. No follow-up. That's just, we did this intervention, and this happened. So this was why it got approved. They did have some nausea, vomiting, abdominal pain, which were short-lived, and mostly were around the time of the procedure. So another study from the Italians. Italians are very creative. I would never thought they were fat, but anyways, nearly 2,500 people they pulled in. They were all morbidly obese, BMIs more than 44, and after the intervention, the BMI came down to 35, and the percentage of excess weight loss was around 33%, 34%, which is really, really good. But the most striking thing, at least to me, was the improvement of the comorbidities that are associated with obesity. And in this, we talk about hypertension, diabetes, respiratory disorders, that in this study was mainly obstructive sleep apnea, and also some joint pains and dyslipidemias, okay? So then other people say, oh, so one balloon is good, let's do 2 balloons. Okay, so this is, and then they made the reshaped duo. And again, this is a space-occupying device, and there are 2 independent balloons, okay? They're filled each with 400 cc's of water and plus your methylene blue, and they are connected with a silicone tube, okay? If one deflates, you have another one, and it will prevent migration. So good deal, right? Again, stays there for 6 months at a time, and it was approved a little later in 2015. So when you look at the data, they did this reduced trial, and again, it's a prospective randomized trial with this balloon. And they included like 326 patients. Again, intervention group, they held the balloon, and then the other ones were the control. But the difference of this trial was that at 6 months, when they removed it, they unblind the study. And then they tell the people that were in the control group, let's do this. Now you know you were control. I offer you to give you the balloon. So for those who actually said, okay, that's cool, they did for 6 months, and they all were followed for 12 months after the balloon was taken out. And what they found was that patients that on both intention to treat and completed cases, those patients that had the balloon had a 26-27% of excess weight loss compared to those that only had diet and exercise. So which is really, really cool. They were setting up, when they did their sample size, a superiority margin of 7.5. That's what their goal was. They were aiming for that. Where did 7.5 comes from? Because on the adult literature, we know this is the effectiveness of diet and exercise. So they were trying to be better than that, and they achieved it very well. So then they start saying, well, from all of these patients that lost weight, how many of them actually lose more than 25% of excess weight? And they found that pretty much in both scenarios, both statistical scenarios, pretty much half of the patients lost more than 25% of their excess weight. Okay? And again, they were aiming at 35, and they got half of the patients. So this is a very good trial. Okay? And then back to they report their side effects. They were mild for the most part, and as you can see, they were all related to the timing of the device, and they were all managed medically without side effects, and they actually improved with time. Later on, they say, okay, so 2 endoscopies, not cool. Let's reduce it to 1 endoscopy. So then they created Obalon. For those girls that want to pursue surgery, the creator of this is a female surgeon from Long Island. Okay, super smart. So what they did is, let's make this same balloon, and we're going to jam it up into a small capsule, and then make you swallow it. And once it's in your belly, I'm going to inflate it with gas. Okay, and then this is at 250 mLs. But then we'll see you in clinic. You're still not losing weight. Swallow another one. And see you in clinic. You're tolerating well, no side effects. not losing weight, let's try a third one. And so it's more tailored, okay? And again, the length of therapy is about 6 months, and this was just approved by the FDA a couple of months ago. So they did this pilot study back in 2013 where they grabbed people, again, adults in overweight and obesity range. They treat, because they know about the abdominal pain and the reflux and all that from the previous experiments, they said, let's try you with PPIs before and after the balloon. We'll see you on a weekly basis. If you don't lose weight, 4 weeks later, we'll make you swallow another balloon. And then 8 weeks after the first visit, you're still not achieving what we want you to achieve in weight loss, swallow a third one. And we'll see you for 12, we'll follow up for a total of 12 weeks. So this is what they found. On week 4, 8, and 12, they noticed a steady decrease in weight across time. And again, their excess weight loss was from 12% in 4 weeks to 36% at the end of the trial. And their BMI went from, on average, from being obese, because remember, they were all between 27 and 35. Now, now they were only fluffy. Okay? They were just cuttable. Okay? So that's a good thing. And back to the point, by decreasing your weight, you're also decreasing your comorbidities associated with this. So then, this is a new trial that's still ongoing, but these are preliminary data that they published on their bariatric surgery meeting earlier this fall. And what they did is a year follow-up. Okay? So it's a randomized sham-controlled trial like the Obalon trial, and it's double-blinded. So first you have your intervention, and then you have your post-follow-up intervention, right? So they only included for the analysis those patients that were able to fulfill at least 18 weeks of balloons with more than 2 balloons in, okay? So they grabbed 366 patients in 15 centers around the US. That's really, really good. Just try to manage the logistics. That's tough. Both genders, BMIs from obese to morbid obesity, and they were unblinded at 24 weeks. And this is what they found. Sorry for this, but this is the best thing I could ever got from them. So the mean percent of total weight loss at the end of the intervention phase, which is 24 weeks, was that people lost about 8% of their total weight, And for the next year follow-up, they noticed that they remained low. Now, if you pay close attention, you will see that actually there's a slightly tendency to increase weight, but they will make an argument that it was not back to their baseline. Okay? Again, this is in conjunction to diet and exercise and all those nice things that we are already doing. Okay? So then we're talking about what is happening after the balloon. So the first author, what they did is, let's do sequential balloons. So if we do therapy for 6 months, it's okay. Let's do it one and over and over and over and see how it goes. So they noticed that sequential balloon therapy over a year seems to achieve greatest weight loss compared to single therapy, okay? But they did acknowledge that around half of their patients actually were able to maintain weight, and those that actually start gaining weight was less than 10% of their original weight. So it's okay. Okay, and then there's other prospective studies where they use a single balloon, and again, after 12 months after their follow-up, they did have a little bit of weight gain, but still was significantly lower than before their before trial. So then we talk about, let's compare balloons versus just modification. We talk about diet and exercise alone. Now let's talk about behavioral modification. So this study, what they did is, let's put a single balloon plus diet and exercise versus only behavioral modification. And they noticed that patients with the balloon lost significantly more weight during the intervention phase, but they did regain weight afterwards, okay? Compared to the patients that were only on behavioral modification, they did not lose the same amount of weight, but interestingly, at least they remained stable They didn't regain it. So they talk a little bit about, they hypothesize about their commitment actually to lose weight. And they did acknowledge that some of them might have actually predicted that they had the balloon inside of them. So they did something interesting. This is a busy table, but what in the first box is this is a standardized questionnaire that will assess 3 domains in your psych component, right? Your cognitive restraint domain, your emotional eating domain, and your uncontrolled binge eating, okay? And at 3 months, they noticed that patients that with the intragastric balloon had a significant decrease in these scores, which we anticipate because their stomach is full. But if you ignore the rest and you see at 12 months follow-up, there's no difference between that, okay, in these 3 domains, which makes me wonder that we are actually dealing with a more complex disease than we think, because there is a big component of supratentorial component of the obesity, okay? And if we don't address this, no matter how many balloons we do, they will rebound back because we are not modifying their behaviors, or we're not being effective enough to have a sustained change in that behavior. So what's the pediatric experience? Very limited. Late 1990s, Dr. Ivan van den Plas in Brussels, what he did is he grabbed randomly 5 kids who were obese, who, their primary care doctors said, like, he's diabetic, hypertensive, sleep apnea, and he fails everything. Do something. Go on. So he said, okay, sure, we'll put a balloon. And on average, they put 500 to 700 mLs of fluid in. And interestingly, this is what happened when you don't plan well your studies, is that none of them lost weight. Some of them were actually heavier. And these are not pounds, these are not kilograms. These are actually percentiles of weight. So for those who are interested, Pediatrics has a nice paper about of new growth curves for obesity, where they plot what's the 100, the 110, the 120, the 150, the 200 percentile. So these are percentiles. So these patients were 148 percentile for the age and gender, and they end up, after removal of the balloon, 153. So what happened? So they say, well, hunger and their ability to eat decreased initially, but they had a gradual adaptation, and they end up eating a lot. And they were able to overcome that barrier. What happened here? Back to the previous study. They did not select their patients correctly. They did not make sure the patients were ready and committed. And you can always bypass whatever we do. So later on, they woke up, they dust themselves, and they come up with something a little bit better. So they grab 14 patients, all teenagers, and they use a single balloon, 700 mLs of saline, and then everything went smoothly, and here you go. They were all obese, okay? And when you look at their intake and their actual caloric intake was significantly better after the removal. So they did actually improve in terms of weight and in terms of their caloric intake. So you say, okay, I buy. But then when you look at their distribution of change in BMI across these 13 patients, they don't look very, very good. So I want to point out 4 patients, okay, that they did have a significant change in their BMIs. And then the question that I raise again is, what is the difference from these 4 patients from the rest of the cohort? Okay, and maybe the question will come back with, maybe those patients were more committed to lose weight compared to the rest, okay? So then Italians, back to the Italians, they say, okay, let's try the Obalon, the one that you swallow, okay? And what they found is that, yes, they were all very, very obese, okay? And for sure they have NASH. They made a big fuss about change in lipids, but I will argue that, to start with, they're not high enough to even start therapy. But anyways, they made a big fuss about improving in this lipidemia, which, if I would be the reviewer, I would scratch that sentence. And then they make a big fuss about improvement in their insulin sensitivities. And I'll dodge some shoes that Dr. McBee might throw at me because I know he hates HOMA IR. But, I didn't do this trial. Just let it go. Okay? Just let it go. I know HOMA IR and endocrine people, but we'll take it as it is. Okay? And then what they did is, okay, let's just look at those patients that actually were more compliant than the rest of the people. So 50% were very, very compliant. And they noticed that they were the ones who had a more significant weight loss, a more significant decrease in their BMIs, Z-scores, and even in waist circumference. Okay? Back to the point of selecting patients correctly. So, although we're going a little bit back in time, we have a syndrome that is called Prader-Willi. And these patients are known to be prone to morbid obesity. Okay? So they actually started doing this balloons for them. Okay? And so they grabbed 12 patients. They were all, 8 to 30 years, so it's a huge gap of age. But they put balloons, okay? And they also did restrictive diet, make sure they were 700 to 1,000 calories per day, semi-liquid food for 2 weeks. And then they stretched it to 4 weeks because they did have complications from this procedure, okay? They have B-sores, they have gastric rupture, and they actually, one patient died. Not really cool. But anyways, they were smart enough to do DEXA scans to assess body composition, fat, lean body mass, and things like that. And then they assess the overall 8-month follow-up. So what they found is that, yes, there is a significant decrease in weight and BMI. The percent of fat actually decreased, which is a good thing. But I will argue that there's one component here that's your lean body mass that actually also decreased. So when you're losing weight, you want to lose fat, but you don't want to lose muscle. So you need to be smart about it. And you say, oh, Dr. Chapa, it's just one point in time. But if you're doing sequential balloons, and this is a trend, you need to be careful. You really, really need to be careful of what you're doing. So busy table, but I'll summarize it for you. They claim that this was sequential, but it's not sequential because you can see that there's months or even years between balloon 1 and balloon 2 and balloon 2 and balloon 3. So they're actually not sequential. They're actually, okay, I took it out, you gained weight, you fell, so okay, let's put it again. So it's completely different events, or 3 events completely different. And what you can see is that some patients did good, but some of them didn't, okay? And they claim that the younger age is the better, but very few samples to make that statement, okay? So lastly, what are the indications for bariatric surgery in pediatric patients, which is an FDA already approved procedure? And so we have BMIs that are high, 97 percentile or 40% of your BMI. 40 BMI with severe comorbidities like type 2 diabetes, moderate to severe sleep apnea, pseudotumor cervi, or NASH with advanced fibrosis. Or if you have a BMI greater than 99 percentile, or a BMI of greater than 50 with mild comorbidities, and there's the list of them, okay? Obviously, you already have tried 12 months of lifestyle changes, medications, and you have failed. So this is from New England Journal of Medicine last year, where they did a 3-year follow-up of teenagers morbidly obese that underwent bariatric surgery. And what they found is that, of course, after surgery, the mean weight loss was 41 kilograms. Again, 27% of excess weight loss. 2% and 4%, depending on surgery, they actually increased weight above their baseline. So that means that you did not select your patient correctly. And even though that you did a freaking invasive and irreversible procedure, you were able to cheat and gain weight, okay? And importantly, back to the comorbidities, 40% were hypertensive at baseline, 70% their blood pressures normalized. Again, the same with dyslipidemias and type 2 diabetes, okay? Important thing, at the 3 year mark, they were all iron deficient. They were all vitamin deficient. They had vitamin A deficiency, vitamin E deficiency, they have vitamin D deficiency, they have all the micronutrient deficiencies. So this is not really as entirely safe procedure because although you lose weight, you will have impact in some other areas, okay? So my last thoughts would be that obesity is a very complex, multifaceted disease that, for the most part, is under-recognized and it's underestimated. Okay, it has become an epidemic with devastating consequences that will affect health, quality of life, and of course, profound economic impact in our pockets. And although bariatric surgery has good results, it's an irreversible procedure that will achieve weight loss, but has an increased morbidity and even mortality. Okay, some recent studies have shown that adults have 10-year increased mortality after bariatric surgery just because they have bariatric surgery. So I would be hesitant to do this type of procedures in someone who has a whole life ahead of them. And intragastric balloons are effective to achieve weight loss with minimal weight regain, minimal morbidity, and most importantly, it's a safe and reversible procedure. Can we do better? Sure we can, of course, because we're going to do in LSU, of course. So we need to do better selection of patients, okay? We need to have a comprehensive psychiatric evaluation to make sure that our patients don't have any psychiatric component that will make them eat their ways through their anxiety, depression, or whatever you want to call them, okay? But most importantly, and no one has looked at this, is to make a tool that will assess readiness, not only for the patient, but for the family. This is a systemic disease. If the kid is fat, the mom and the dad are fat, and the siblings are fat. So how many times you've seen a kid that says, well, I'm trying, but he's eating chips. Well, you're buying them for them. Seriously, a 5-year-old does not have money in their pockets. You're buying them for them. So both family and the patients need to be ready. We need a multidisciplinary approach, and Dr. Gonger has an amazing clinic that's already doing that. I'm just hope to tag along. And we have to improve our methodologies. We need to use Z-scores to be able to better assess difference between groups. We need to have better nutritional assessment before and after, and especially long-term. We need to have a close follow-up for these patients, and we need to decrease timing. If we're going to do sequential, which I think we should, we need to decrease the timing between each balloon to make sure it is actually sequential. It's not spaced by a year or something to achieve better results. That's what I think. So for you that ask me, Dr. Chapa, you're coming 30 degrees and it's very, very cold out there. So this is exactly 2 years ago, this is me and my wife. So this is after just one night snow. You can see pretty much compared to the door, how high is that? This is me after coming from work, of course, trying to clear that same pathway. For those who are asking, that's minus 10 Fahrenheit room temperature. And actually, CNN was out there in my front door saying, I think there's a lot of snow out here. So as long as I don't have to shovel snow ever in my life, I'm golden. I am golden. Any questions, concerns, demands, jokes, or cooking recipes for the holidays? I hope that they're light.
Question?
Dr. Chapa, do you have any place which is sort of going, taking market investigation of this whole new thing in pediatrics?
Pediatric Center. So I spoke with the Italian group, I spoke with the reps, and they claim there's someone doing them, but they're very jealous and they don't want to share that. But I went to the clinicaltrials.gov, and I think it's quite outdated because I go there and try to look at people and say, oh, we're not doing that anymore. So I don't know.
And what if someone eats too much, when it takes for you, and if they don't follow the diet, and they become using it automatically?
They will happen what happened with the Prader-Willi babies. Yeah. That's why they had to increase from the liquid diet from 2 weeks to 4 weeks. And they had to make weekly visits because they were able to still eat more. And what Dr. Vandenplas showed was precisely that they were able to adapt and just keep eating. And the stomach is a smooth muscle. I mean, remember just plain anatomy. Your uterus is this big, but after you become pregnant, it comes all the way to here. They kick and you feel it here in the tonsils, right? So again, back to the point that our bodies can adapt to so much insults that we put into them. So back to the point that we need to select them better. And I would be very, very hesitant to put one of these things in someone who's not ready. So that's why making sure that they're enrolled at least 12 months before in like Dr. Gomgor's clinic, and we have followed them, and we know that they're. Well, I know, but I mean, some of them will lose weight, they will regain weight, they will lose weight. I mean, they're trying. That's a different scenario from those that are actually like gaining and gaining and gaining and gaining. So you just like you need to put a white piece of paper behind your monitor to start like plotting them because they're already. Yes. And that's, I think, the problem that most of the adult trials and the pediatric trials have seen, that no matter how good you are doing to screen them based on what we have now, we're not successful in doing that. And that's why patients are having some relapse. Again, back to the point that this is a very complex disease, and there's a big psych component, and there's a big behavioral component. So we need to tackle this. Multidisciplinary approach, I think, would be the best way to deal with this. And
I have a patient who's 2 years old and his weight is 50% high for 12-year-old.
So that's the other thing. I mean, I showed you initially what is the growth, the prevalence of obesity in pediatrics. And what I found across my very, very limited experience is that people tend to say, well, he's not fat because he's tall. Well, let me tell you something. Dr. Naman, you and I, our growth plates are fused. You and I will only grow sideways if we eat. But babies, in the context of someone who is growing in a hyperalimentary state, they will grow sideways, but they also grow disproportionately taller. So for those medical students and residents that are out there, I mean, if you see someone who, regardless of their age, their weight parameters are above the 95th percentile, regardless if they're tall or not, you need to label them as obese, and you need to start, because this is something that starts early on in their lives. We're dealing with them like 12 years later, so try to change a behavior for 12 that has been there for 12 and 18 years. That will be tough.
Thank you for the very nice presentation, and just particularly for our students and younger generation doctors in the audience, I would like to emphasize the importance of preventative follow-up. In pediatric clinics, growth charts are part of our routine evaluation, and I cannot emphasize enough how important they are, because it is like the health report card of the child. And actually on Monday or Tuesday, I believe, I saw a patient referred by one of our pediatricians. Again, for our task is, whenever we see them in clinics for any reason, just to look at the growth chart, and if there is anything to tell, anything to counsel the family with, we should do that, even if it takes a few minutes, because prevention is key. When it comes to severe obesity, which is a BMI greater than the 99th percentile for age and gender, then we are talking about these new procedures, which have some severe adverse effects in themselves. But this child I was seeing, an 8-year-old boy, he has been, when you look at his growth chart, he had new onset diabetes actually. That was the reason I was seeing him, but he was obese, and when you look at his growth chart from age 4 or 5, his weight and BMI percentile have been sequentially going up. His height has never gotten interrupted, so he doesn't have a glucocorticoid excess problem or a hormonal problem. But, and very ironically, his older sister, 19-year-old girl with type 1 diabetes, has been under our care, and this child is just presented with A1C of 6.7%. He has acanthosis, he's severely obese, and we just started lifestyle modification. But some of these things could be preventable, and that's one of our tasks in our clinics. We have a nurse, and we manage children's healthy weight and activity clinic, which accepts referrals from all of our specialists, subspecialists. So we are trying, and for the young generation, just wanted to give a message.
So that's why I brought the residents and the students to type the percentiles and type this, because at least that way you're making it conscious. And half of the room here is about to throw their laptops, cell phones, and their shoes at me because, oh, are you kidding me? We're super busy. But unless you make it conscious, and that's how I make it conscious. If I forget to type there what the weight, the percentiles, and the Z-scores, it's very easy to overlook.
Questions, comments?